Good day. Our topic for today are the thromboembolic disorders postpartum. Now, for the introduction, the risk of venous thrombosis and pulmonary embolism in otherwise healthy women is considered highest during pregnancy and the puerperium. The incidence of all thromboembolic events averages approximately 1 per 1,000 pregnancies, and about an equal number are identified antepartum and in the puerperium. Now for the pathophysiology, Rudolf Virchow postulated that stasis, local trauma to the vessel wall, and hypercoagulability predispose to venous thrombosis development. The risk for each of these increases during normal pregnancy. For example, compression of the pelvic veins and inferior vena cava by the enlarging uterus renders the lower extremity venous system particularly vulnerable to stasis. And here are the risk factors for your thromboembolic disorders. We have obstetrical and general risk factors. The most important of these is a personal history of thrombosis. Calculated risks for thromboembolism were approximately doubled in women with multiple fetal gestation, hemorrhage, anemia, hyperemesis, and cesarean delivery. The risk was even greater in pregnancies complicated by postpartum infection. Indeed, unlikely related, after personal history of thrombosis, the next most important individual risk factor is thrombophilia. Now, thrombophilias. So several important regulatory proteins act as inhibitors in the coagulation cascades. Inherited or acquired deficiencies of these inhibitory proteins are collectively referred to as your thrombophilias. So, this can lead to hypercoagulability and recurrent venous thromboembolism. So, patients with inherited thromboembolic disorders often have a family history of thrombosis. So, inherited thrombophilias are also found in up to half of all patients who present with venous thromboembolism before the age of 45 years old. They may also have a family history of a sudden death due to pulmonary embolism, and they may have a history of multiple family members requiring long-term anticoagulation therapy. The last two, the family history of sudden death due to pulmonary embolism and history of multiple family members requiring long-term anticoagulation therapy, are of greatest clinical significance in patients with thrombophilias. So here are the list of your thrombophilias. We have the factor V laden heterozygote with a prevalence in the general population of 1 to 15%, and the rest are as follows. So one example of your thrombophilias is your antithrombin deficiency. So your antithrombin function as a natural anticoagulant by binding and inactivating thrombin and the activated coagulation factors 9A, 10A, 11A, and 12A. So they might be on the autosomal dominant, wherein type 1 deficiency is the result of reduced synthesis of biologically normal antithrombin. And type 2 deficiency is characterized by normal levels of antithrombin with reduced functional activity. So given such risk, affected women are treated during pregnancy with heparin. And regardless of whether they have prior thrombosis, recombinant human antithrombin can be given. And another thrombophilias is your protein C deficiency. It is an autosomal dominant mutation and is prevalent in 2 to 3 per 1,000 population, but many of these individuals do not have a thrombosis history because the phenotypic expression is highly variable. They are associated with 6 to 12-fold increased risk for venous thromboembolism, and the treatment for this includes anticoagulants. Another thrombophilias is the activated protein C resistance factor V Leiden mutation. It is the most prevalent of the known thrombophilia syndrome. This condition is characterized by resistance of plasma to the anticoagulant effects of activated protein C. Diagnosis during pregnancy is performed by DNA analysis for the mutant factor V gene. Also included is the hyperhomocystinemia. It is the most common cause of elevated homocysteine. The C667T thermolabile mutation of the enzyme 5,10-methylene tetrahydrofolate reductase. So the inheritance is autosomal recessive. The treatment includes the anticoagulants, vitamin B6, B12, and folate. The acquired thrombophilias examples include the antiphospholipid syndrome, heparin-induced thrombocytopenia, and cancer. Now, for the antiphospholipid antibodies, these autoantibodies are detected in approximately 2% of patients who have non-traumatic venous thrombosis. So, the antibodies are directed against cardiolipins or against phospholipid binding proteins such as beta-2 glycoprotein 1. They are defined by a number of clinical features. In addition to a vascular thrombosis, these include at least one otherwise unexplained fetal death at or beyond 10 weeks, at least one preterm birth before 34 weeks because of eclampsia, severe preeclampsia, or placental insufficiency, or at least 3 unexplained consecutive spontaneous abortions before 10 weeks. Now, for the deep vein thrombosis, during pregnancy, most venous thromboses are confined to the deep veins of the lower extremity. 70% of cases are located in the iliofemoral veins without involvement of the calf veins. Most cases during pregnancy are left-sided. Classic thrombosis involving the lower extremity is abrupt in onset, and there is pain and edema of the leg and thigh. The thrombus typically involve much of the deep venous system to the iliofemoral region, and the reflex arteriospasm can cause a pale, cool extremity with diminished pulsations. Common sign or calf pain, either spontaneous or in response to squeezing or to Achilles tendon stretching, can be elicited. And between 30 and 60% of women with an asymptomatic pulmonary embolism have an asymptomatic acute deep vein thrombosis. Now for the diagnosis of your deep vein thrombosis, first is the compression ultrasonography. It is non-invasive technique and is currently the most used first-line test. The diagnosis is based on the non-comprehensibility and the typical echocardiature of a thrombosed vein. Next will be the magnetic resonance imaging. This imaging technique allows excellent delineation of the anatomical detail about the inguinal ligament. The diagnosis of iliofemoral and pelvic vein thrombosis can be elicited in these diagnostic tests. Next will be the D-dimer screening test. This specific fibrin degradation of products are generated when fibrinolysin degrades fibrin, as occurs in thromboembolism. And lastly, venography. These are invasive contrast venography that is the gold standard to exclude lower extremity deep vein thrombosis. And now for the management of deep vein thrombosis. Anticoagulation is initiated with either unfractionated or low molecular weight heparin. Graded ambulation elastic stockings are fitted and anticoagulation is continued. Graduated compression stacking should be continued for 2 years after the diagnosis to reduce the incidence of post-thrombotic syndrome. This syndrome can include chronic leg paresthesias or pain, intractable edema, skin changes, and leg ulcers. Now, for the heparin-induced thrombocytopenia, there are two types. The most common is a non-immune, benign, reversible thrombocytopenia that develops within the first few days of therapy and resolves in approximately 5 days without therapy cessation. The second is the severe form of heparin-induced thrombocytopenia. It is immune reaction involving IgG antibodies directed against complexes of platelet factor 4 and heparin. When severe, HIT paradoxically causes thrombosis, which is the most common presentation. And now for the management of heparin-induced thrombocytopenia. So when HIT is diagnosed, heparin therapy is stopped and alternative anticoagulation is initiated. Other agents include urdanaparoid, which is a sulfated glycosaminoglycan heparinoid, the fondaparinux, which is a pentasaccharide factor 10A inhibitor, and the argatroban, which is a direct thrombin inhibitor. Now, for the anticoagulation and delivery, the effects of heparin on blood loss at delivery depend on several variables: the dose, the route and the timing of administration, the number and depth of incisions and lacerations, the intensity of postpartum myometrial contractions, and the presence of other coagulation defects. So heparin therapy generally is stopped during labor and delivery. Restarting the unfractionated or the low molecular weight heparin no sooner than 4 to 6 hours after vaginal delivery or 6 to 12 hours after cesarean delivery is recommended by the experts. Slow intravenous administration of protamine sulfate generally reverses the effect of heparin promptly and effectively. Serious bleeding may occur when heparin is in unusual therapeutic doses is administered to a woman who has undergone cesarean delivery within the previous 24 to 48 hours. Next will be the pulmonary embolism. Although it causes approximately 10% of maternal deaths, pulmonary embolism is relatively uncommon during pregnancy and the puerperium. The incidence ranges 1 in 7,000 pregnancies. There is almost equal prevalence for antepartum and postpartum embolism, but those developing postpartum have a higher mortality rate. Massive pulmonary embolism, it means embolism causing hemodynamic instability. Acute mechanical obstruction of the pulmonary vasculature causes increased vascular resistance and pulmonary hypertension followed by acute right ventricular dilatation. Moreover, circulatory collapse requires 75 to 80% obstruction, and they are most likely large and likely a saddle embolism. If there is evidence of right ventricular dysfunction, the mortality rate approaches 25% compared with 1% without such dysfunction. And now for the diagnosis of pulmonary embolism. It includes the multi-detector computed tomographic pulmonary angiography, which is currently the most widely employed technique. Next will be the ventilation perfusion scintigraphy lung scan. It involves a small dose of radiotracer such as intravenously administered technetium 99M macroaggregated albumin. Next will be the magnetic resonance angiography. Although this technique has a high sensitivity for detection of central pulmonary emboli, the sensitivity for detection of segmental emboli is less precise. And we have the intravascular pulmonary angiography. This requires catheterization of the right side of the heart and is considered the reference test for pulmonary embolism. And now for the management of pulmonary embolism. First is your vena cava filters. It is used with massive emboli in patients who are not candidates for thrombolysis. It may be inserted through either the jugular or femoral vein and can be inserted during labor. We also have thrombolysis. Compared with heparin, thrombolytic agents provide more rapid lysis of pulmonary clots and improvement of pulmonary hypertension. Example is the recombinant tissue plasminogen activator, alteplase. That's it for your thromboembolic disorders and postpartum period. Thank you for listening.